amniotic fluid embolism. Okay. So before that, if you want to classify your answer uh, related to this theory of this patient related, surgery related, anesthesia related, and for example, if it is pregnant patient, so pregnancy related. So this is specific, of course. So if you just like 1 day ago, someone had just asked me this question: liver abscess. Okay. So what will be the anesthesia concern? So I asked him that this data is insufficient. You have to tell the age, the sex, any other comorbidity. Okay. And then this is one thing, and then surgery related, whether it is laparoscopic, whether it is open. Okay. So specifically, liver abscess will, of course, it will depend that how much is the size. Usually it will be done open, but maybe a surgeon might want to do it laparoscopically. So if you just like this is just an example that whenever you want to classify, you have to see the any differential diagnosis you should make like this. Okay. So now come back to this amniotic fluid embolism. Okay. So what will be the differential diagnosis? If, for example, I give you a scenario that a 28-year primary is in active labor, okay, and had epidural infusion going on, okay, and then suddenly you are being called, that patient is collapsed, okay. So as keeping this formula in your mind, how will you tell the answer that what are the possible causes? Anyone, please.
Sir, patient is having labor, so most probably the patient may having pulmonary embolism and amniotic fluid embolism.
No,
Maybe
you are not.
we are giving.
Listen, Atik bhai, patient related, surgery related, is like pregnancy related, anesthesia related. How can you directly say that it is pulmonary embolism?
Say in DD, I have told in DD.
No, again, I am just telling you that try to classify according to this formula.
May I say
Yes,
something?
Atik. Yes, Azam bhai, bol.
Sir, I think being an anesthetist, I will search the cause of the condition of the patient, because the patient is on epidural, so might have this catheter migrated into subarachnoid space, and the unintentional or unnoticed this local anesthetic is, causing this situation.
So first of all, like of course, the management will be airway breathing circulation. But first thing as an anesthetist, you will see what was the dose of epidural going on.
Yes, sir.
Did he receive any bolus? So maybe it is related to epidural. Okay. Then, of course, what is the picture? For example, what was the preceding events? Like was the BP fall? Okay. Was there tachycardia? Okay. How much, like what was the stage of labor? Okay.
Sure.
So you will be classifying it, Atik bhai. That's what I was trying to say, that you will try to classify according to this. So if patient related causes, what may be the patient related factors? Patient related factors may be cardiac, respiratory, endocrine, like endocrine or metabolic, neurological. Okay, so there may be some others, but usually at least cardiac, respiratory, neurological, endocrine. And sir, this pregnancy related maybe amniotic fluid embolism. Maybe the patient in active labor can have on for example this one on oxytocin can have something related to pregnancy, like for example maybe patient has abruption, patient may have uterine rupture. Okay, so if you are creating a differential diagnosis, you will go in this way. Okay, and anesthetic related, as I told you, that maybe there is increased dose, bolus dose, as Azam Bhai told, catheter migration. Okay, or anything, patient is maybe hypovolemia, and then you can expand your answer, but your approach should be like this. So cardiac event, maybe MI, patient might have some coexisting problem, then pulmonary embolism can occur. There may be, like according to the scenario, according to the situation, there may be, for example, eclamptic patient may have this one. So you will be, your approach, if you are managing the patient, you will immediately have this ABC approach. You will stop epidural. Okay, you will call for help, and then you will say that resuscitation and management and differential diagnosis will go side by side. Okay, okay, so that's how you will proceed. Okay, so anything else in your mind, Atik bhai?
No, sir. But sir, in exam, mostly the people want you that they want important point from you. Then they said or. First of all, they want important things from your mentioned first.
No, even then you will like for example, if they have given the hint of epidural, if for example patient does not have epidural, then you can say, you are right, I'm not saying that this is wrong, I'm just telling you that if you classify your answer, then it will be easier for you, you will not miss anything. Okay, if if you will not miss any of the factors, then they will not say anything. Okay, so what factors will lead to, like for example, now specifically what will be the features which will be heading towards amniotic fluid embolism?
If the patient is awake, then he will tell you that there is impending, yeah, or shortness of breath. And second is the patient may be hypertensive.
Okay,
And maybe having tachycardia,
what else?
and
Yes, Atik bhai, what was saying?
sir, I was telling you that sir, in the amniotic fluid embolism,
Mhm.
the patient will tell you the symptoms of shortness of breath and hypertension, and the patient will be cardiac collapse. Maybe patient they feel cardiac collapse, and while under GA, the patient will not say anything, but there will be oozing from the site, and the patient may have hypertension.
Okay. So, like patient, if patient is in active labor and there is sudden hemodynamic collapse, so like you will be looking at it. There is no specific test at that time to to get the diagnosis. So your approach is actually generalized. So your approach will be that if patient conscious level is deteriorated, you will secure the airway. If patient is in shock, you will start the fluid resuscitation. If patient is in cardiac arrest, you will start CPR. You will do this left uterine tilt. If patient is in arrest, you will try to immediately do the peripartum cesarean section. Okay. So these are the things which you will be doing. Okay. So like here they have just mentioned here. Okay, possible causes: hemorrhage, embolism, MI like cardiomyopathy or any coexisting amniotic fluid embolism, the preeclampsia, local anesthesia toxicity, high regional. So almost we have yes anaphylaxis. Okay, there may be patient might receive some medication which lead to anaphylaxis or any intracranial. So that's what I just actually just talked you out, that whenever you are describing, actually this is for any collapse, but for specifically a pregnant patient, your answer will in addition to the all others, they have not written here endocrine problems, but it may be the reason. So whenever you are dealing an unknown patient without any data, so you will just say your resuscitation management and evaluation will go side by side. In MCQ, whenever they are asking you some question, they will give you some hint which will be heading towards something. Maybe they will tell patient received antibiotic, and then after that patient, so your answer in that scenario will heading towards anaphylaxis. If the patient is on epidural and they say that the patient received epidural bolus, and suddenly after some time patient become unstable, so your answer will be, so you will definitely find some such MCQs which will be having some hints which will make it towards one side or other side. Okay, there is no specific management for this. It is a totally generalized approach. Okay, so specifically we will just have a look here.
Salam, sir.
Walaikum assalam. Yes.
Sir, I'm Dr. Heba. I have a question to ask.
Yes.
Sir, if patient is undergoing C-section and doctor has given spinal, so if a patient also goes as amniotic fluid embolism, so how could we differentiate between high spinal or amniotic fluid embolism?
That's what I'm telling you, that you will be going in probability. Okay, if you have given spinal and after that suddenly patient goes, so your first probability will be towards spinal. And for example, even if it is amniotic fluid embolism, your management is the same. Okay, by the way, if you have high spinal, like we have, because we have discussed this thing before as well, there is a concept of high spinal and there is a concept of total spinal. So my question will not be this one. My question will be how to assess the level of block.
Actually, you will first of all you will resuscitate the patient, as Sir Zishan told, that you will do the ABC, will give fluids, inotropes. He will hemodynamically stable the patient. Then you also draw blood for certain investigations to support your diagnosis. Then you can understand that what would be the probable cause. Like if you give intralipid and the patient is not improving, so that is very less likely that it is toxicity or any other thing, or the patient is not improving. In amniotic fluid embolism, the patient would not improve with the passage of time, but in high spinal or total spinal, the patient will gradually improve during resuscitation.
Yes, and of course, for
So
example,
in in the total spinal, sir, there will be say that there will be numbness around the fingers, thumb. Sir, that is, sir, in Urdu
Perioral,
it's
yes,
referred
perioral
to
numbness, metallic taste.
not perioral numbness. It is a numbness around the thumb, that it is high spinal. If the patient goes suddenly after spinal, and the position of the patient is the head down, then it's most probably it is total spinal. Then you have to intubate that patient. ABC will be the action of.
Okay, let me just tell you some things. Just Dr. Hiba, can you answer my this question? How will you assess the level of anesthesia? Because this is very important to understand the whole concept. How you assess the level of block after giving spinal? You have to check actually three things: sensory, autonomic, and motor. Okay. So this will give you a hint even before patient collapse. Maybe it will give you some hint that you have achieved a high levels. Okay, this is one thing.
Okay, sir.
The other thing, as Dr. Atik was saying, that there will be numbness in the finger. So actually sometimes there is generalized approach, there is generalized symptom, and you cannot differentiate. But certain signs, for example, if there is severe hypotension, as a result of low blood pressure, the usual response is increased heart rate. Okay. So,
Yes,
but
sir.
if, for
Yes, sir.
example, if it is high spinal, okay,
Ji.
usually there will be combined decreased BP and decreased heart
And
rate.
very bad.
Okay.
Yes, sir.
So if it occurs, then another thing, you give vasopressor, phenylephrine, or for example, ephedrine, or in our setup, we give epinephrine. For example, as soon as BP improves, the conscious level improves, and everything improves. So this was most probably it was high spinal. Okay.
Yes.
But
Yes,
if, for
yes.
example, it is total spinal, even if you improve the blood pressure, patient will not be able to breathe, because total spinal we say when there is cervical involvement. Okay. So the diaphragm is gone. Okay. So if diaphragm is blocked, even whatever you do, patient will remain apneic. Okay.
Yes, sir.
So what even blood
Okay.
pressure improves, because if it is total spinal or high spinal, patient will respond to your therapy. Okay. But if, for example, if it's something serious more serious than these things, like amniotic fluid embolism, like pulmonary embolism, okay, or some neurological event has occurred, the patient will not respond. Okay. Here in my career, I just faced one time. I was maybe third year resident. I give spinal and I make the patient flat. And when I start, because my way was that I always used to tap the patient. So when I tap, patient was not responding. So immediately I intubated. I gave epinephrine. Maybe I don't remember how, I think half ampule. And immediately I asked them to proceed for cesarean. This was my just reflex. And actually I intubated. But as soon as they delivered the baby, and because I did not massage, I did not do massage because there was no time as typical our scenario. So I did not have time to check the heart rate and everything. I just trusted what I was doing. I gave atropine and epinephrine, and actually within few minutes, as soon as the baby was delivered, after some time, actually I extubated because the patient was all okay. So this is one example that if it is that, because that patient definitely has only high spinal, there may be some high segments were involved, and there was cerebral hypoperfusion. Cerebral, actually not even sorry, hypoperfusion. So even if, for example, there is severe hypotension, not even high spinal, for example, I said high spinal, even it was not high spinal. Okay. It was only cerebral hypoperfusion. Because of severe hypotension, patient can become unconscious transiently. Okay. So with my patient, it was even not high spinal, because that in the time patient recovered, maybe it was not high spinal, maybe it was high spinal.
Also, patient will complain of vomiting.
Yes. Like,
Nausea, vomiting.
actually this is a very vague. There is no guarantee at that time. Yes, if patient is in active labor, there are chances. If the patient, if you give spinal and immediately it occurs, most probably it is related to spinal or epidural, whatever you are using. If the patient becomes unconscious after the delivery of the baby, most probably it is amniotic fluid embolism. But amniotic fluid embolism can occur before, and sometimes they deliver the baby very quickly. Okay. So maybe the spinal effect can come after 15 minutes as well. So you can have high spinal even after the delivery of the baby. And you can have amniotic fluid embolism even before the delivery of the baby. You understand? So you cannot say anything by guarantee. You will just see the response of your management, and this will only dictate you. I hope you understand. But even for your practical purposes, because we are discussing this scenario, my suggestion, if you are, even if you are giving spinal, always have 2 IV lines. Never ever give spinal anesthesia to a patient without 2 IV lines. This is my message to all my junior colleagues, and even my colleagues and my seniors even. Okay, never do this. Why? Because when we give GA, if we have good 1 IV line, maybe we can keep the patient in a way that IV line is properly fixed, and but when the patient is awake, patient can move the hand, then there is no guarantee that whatever fixation you have done, this will remain like that. So 1 IV line can come at any time, and try to put it on opposite sides, so that if something happens on one side, maybe you have another IV line. So this is just a practical message that never proceed. Yes, another exception to it is if you see that IV lines are good and you are able to visualize the IV lines, then okay, no problem, you can take a chance. But if you see that you are hardly having a 1 IV line which is streaming to you, then you should, unless there is emergency, this is my message, never proceed without 2 IV lines, because it is less likely that 2 IV lines patient will pull out. But 1 IV line can come out in a flash. And I have faced it, a terrible incidence in laparoscopic sleep gastrectomy in a very obese patient, in which I just took it lightly and started the case. And suddenly what happened, only the arm which was fixed in the armrest fell down, the IV line came out. The light was closed, laparoscopic bariatric surgery was going on, and I suffered like anything. And so suddenly when they make a position, because if someone you have done this laparoscopic bariatric surgery, they make the head side up, and they just make it as if they are standing the patient. Okay, so when the patient head foot side is totally down, there is every likelihood of having hypotension. So that was a terrible message for me. So I'm just telling you that sometimes these practical tips, and you should never, because you are prone to do mistake when you become senior. Okay, when you as much as senior you become, there is more chances of you doing some mistake. So, and this is it. Okay, so just a second.
Thank you, sir.
So this is,
Excuse me, sir.
yes,
Excuse me,
Atik bhai. Yes.
How will we differentiate between pulmonary embolism and sir amniotic fluid embolism while going under GA?
How, usually amniotic fluid embolism is usually subacute. Usually it can be very acute, but usually it is subacute, and there is no way to actually by surety you can
No, sir.
say.
Sir, in the pulmonary embolism,
End-tidal may be helpful.
end-tidal, and sir, with the JVP and end-tidal, and in the
No,
pulmonary
just
embolism,
a second. I think by just a second. How? What do you mean by JVP and end-tidal?
sir, when the patient will be under GA.
No, that what is the interpretation? If, for example, you are saying JVP, what do you mean by JVP?
So GVP will be raised.
So it cannot be raised in pulmonary embolism?
In pulmonary embolism, it will be raised, not in amniotic fluid embolism, sir.
No, it can be raised. It can be raised in any condition if there is any right heart failure or strain. then it can be raised.
Okay, so you see, this is what they are saying to diagnose acute hypotension or cardiac arrest, acute hypoxia diagnosed by dyspnea, cyanosis, or respiratory arrest, coagulopathy, or severe clinical hemorrhage in the absence of other explanations. There is no way what you are telling, Atik bhai, this can occur in both of them. Just tell me one thing. Just now we are discussing just to clarify. Maybe it will be of help for juniors. Just tell me one thing. What happens in embolism? Any embolism, whether it is air, whether it is fat, whether it is thrombus, or whether it is amniotic fluid. The ultimate result is blockade of pulmonary artery in one way or other. Maybe acute, maybe subacute, maybe total, maybe partial. So what happens? You said raise JVP. Why there is raised JVP? Because the back pressure will come in the right atrium, right ventricle and right atrium. So JVP will be raised. Okay. And why there is no end-tidal CO2? Because the pulmonary artery going towards the lungs. So this is closed. So no lungs, no blood flow to lungs, and then no
That
lungs.
space will, yes.
Okay. So there is a left heart. Left heart will not receive any blood. So there will be cardiac output will khalas. Okay. So this is the sequence of event in any. Yes. Now the problem, the what is difference between acute or subacute is that they say that in amniotic fluid embolism and in fat embolism, they propose a immunological reaction. Okay. Rather than physical only. Because in thrombus or air, or to be very fair, air, definitely it is physical obstruction. Okay. But here it is plus minus. It is said that amniotic fat embolism or amniotic fluid embolism may be as a result of immunological reaction. So when there is immunological reaction based theory, it is releasing mediators which are creating this problem. Okay. So this is the features which you are telling is not the differentiating features. Okay. So that's what I was telling you. Anesthetic factor, pregnancy related factor, air embolism, and this and that. Okay. I hope you understand, Atik bhai.
Yes, sir. Yes, sir. But what about the bronchospasm? If bronchospasm will occur in pulmonary embolism or in amniotic fluid embolism?
It can occur in both of them. It can occur in both of them. You see there what is happening here. Hypoxia is an early feature and likely attributable to the three processes. Early on, the main cause are pulmonary vasoconstriction and cardiogenic pulmonary edema secondary to left heart failure. Later, as two primary processes resolve, hypoxia is maintained by the development of an inflammatory capillary leak within the pulmonary vasculature, leading to non-cardiogenic pulmonary edema. Actually, you know, when massive pulmonary embolism will occur, it is only theoretical. Remember one thing, if it occurs, sometimes it will not give you the chance to identify. Bronchospasm is a very vague thing. Okay. So I don't think so. There is clear cut. Yes, if you have fat embolism, you are watching fat everywhere, maybe in the conjunctiva, in the urine, in some other parts. Okay, petechiae. So that is, yes, that is something it can give you hint. But here, unfortunately, there is, yes, coagulopathy is there. Coagulopathy is one of the things, but coagulopathy can occur in fat embolism as well. Why petechiae occurs? There is coagulopathy. That's why these things occur. Okay. So I don't think so. I don't have clear answer. Okay. So, okay. One more thing I just wanted to tell you that this, especially the people who are appearing in UK Ireland exam, or I think I will suggest you people to also, this is confidential inquiry on maternal and child health. Okay. So this is CMAC. So CMAC actually every 4 years or 5 years, they do a data, they probe into the causes of all the maternal mortalities, and then they publish some data. Okay, so in every report, maybe sometimes hemorrhage becomes the primary cause, sometimes embolism becomes the primary cause, sometimes hypertension becomes the primary cause. It is changing. Okay, so you should be reading it because especially in their part of world, if you are appearing in their exams, they will be asking you, what if they have asked the question, what is the most common cause of most something. So actually their question will be according to the findings from that CMAC source. So for your knowledge, you can do it, but I'm not sure what happens in other part of world who are not following this. So they can, maybe they are following some book or something, maybe the data is different. Okay, but usually it remains one, some cause bypass the other one, but the basic thing remains the same. Okay, so I think this is the chunk of the topic which we discussed. The same thing they will be telling,
Sir,
perimortem cesarean.
what would
Yes.
be the treatment? So treatment is important.
There is no treatment. Supportive
What,
management.
what about the DIC which occur in the amniotic fluid embolism? How
If
can we treat it?
if coagulopathy occurs, you will be treating the coagulopathy. If patient is documented embolism, you will go for thrombolytic therapy. After initial management will be the same. Later on, you will be doing something. Okay. Later on, initially, there will be the same thing, which is, what is the treatment of DIC? There is no treatment. You're just trying to remove the cause, and you are having the symptomatic. You may follow it with FTPs. You are giving anticoagulants even. Okay.
What
Because
would
there is,
happen if, sir, what would happen if the patient collapse while the patient is in labor room?
you will do the CPR, cardiopulmonary resuscitation,
And
according to.
how much CPR we will do,
What do you mean by that?
and how
Sir,
what
he
are the
means,
steps?
sir, he means that for how long you will do CPR and immediately shift to the OT for the cesarean section.
No, they peripartum cesarean not to be even shifted to any place. They will open the abdomen there. They will remove the baby wherever the patient is. I have, by the way, it's my luck. In my career, I have seen one time in Saudi Arabia, a lady going on her foot who had peripartum cardiac arrest. They delivered the baby in the emergency. They packed the abdomen. They resuscitated the patient, and patient revived. And I was on call consultant when the time when I came, the patient actually was, that time patient was in OR. And actually this patient survived like anything and went on her foot. Okay, so actually they
For 5
peripartum,
minutes you do CPR. For how many minutes?
you will start, there is actually, what they claim that start preparing for cesarean section and do it at 4th, 5th minute.
It is different between CPR guidelines that there should be 5 minutes now, sir. And sir, what about what the time? What is the position of the CPR, sir? That is us.
CPR, they put the left uterine tilt, they do it a little higher on the chest. Rest of the things are the same.
lateral tilt, and a little higher. Okay, sir, you're right.
Anything else? Okay.
Sir, and the this amniotic fluid embolism is also called anaphylactic reaction.
Okay. What is difference between anaphylactic reaction and anaphylactic reaction? That's what I was telling you, immunological response, Atik bhai. That is immunological
Yes,
response, which is, okay, just a second, you will know it. So I will ask someone else. Hiba, where is Hiba? Dr. Hiba, can you answer this question? What is difference between anaphylactic and anaphylactic reaction? Or anyone? Okay. Yes, Hiba.
Sir,
Yes.
anaphylactic reaction, there is vasodilation,
No.
and rest of the same. G?
No, 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 no. This is not the answer.
Sir, actually, I was just telling about anaphylactic reaction, anaphylactoid. I don't know.
Yes. Yes. Now hand over the question to other one. Because you know the things which are not written in your holy Manhus Morgan Sharif, unfortunately, you people don't know. Okay. So
Hmm.
I am very happy. I am very happy. I want all of you to understand one day before I die. I want you, all of the anesthesia people, to throw away this bloody Manhus Morgan Sharif. I'm really sorry to use this word, but unfortunately, you are not at fault. The source you are reading is at fault. You will never find a good concept in that book. So please find your enemy and be away from it as early as possible. Anyone else? What is difference between anaphylactic and anaphylactoid reaction? Azam bhai, do you know?
Sir, actually, Usman is very fond of Morgan Sharif, sir.
No,
I
no
told him
problem.
that.
No,
Uh,
I cannot change the mind, but I will keep my jihad.
Sir, I have definitely read Morgan, but that is not the only book that I have read. I have read
I
many
have read
books also.
also. I have read also,
Yes,
and I have put
yes,
lanat
I
on
know.
it after failing so many times. And that's why I am begging you people to
Yes, yes.
get
No,
rid
no.
of it.
Only Morgan is not enough. I
Yes.
definitely agree. And only
Okay.
Morgan is not
So
enough.
now I'm sorry, I become very emotional when I'm talking about this curse. I apologize for that. But please come back to the question. What is difference between anaphylactic and anaphylactoid reaction? Atik bhai, you tell.
sir, the anaphylactic reaction is with the some IG, some antibody,
It is
immunological.
IgE mediated, okay? It is mediated through IgE, and
IgE
it,
mediated. And
yes, usually,
anaphylactoid reaction is through complement mediated, sir.
no, 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 not complement mediated. There is no first exposure is not needed. Usually, it can occur instantly, and the drug
Yes,
itself
yes.
becomes the cause.
Direct stimulus. Yes, direct
Direct
stimulus on the
stimulus.
mast cell and histamine cells.
There
Direct
is
effect on.
no in between involvement of IgE. Okay,
Yes.
so Hiba, now you understand the sign and symptoms will be the same. There is no difference in sign and symptoms. And then
Okay.
you will be following it. Actually, maybe the next topic is anaphylaxis. Next or after next topic, you see this one topic is anaphylaxis. Okay, so we will
Sir,
inshallah. Yes.
I have started my training a week ago, so I would love कि आपको अच्छी book suggest करें initially.
Now I will pull you away from books. Read articles.
Okay, sir.
There is no need for reading any, you know, book reading was of ancient time, of our
Hmm.
grandfathers. Unfortunately, please, I am if any of the I am 100% sure none of the senior will listen to our discussion, but even if they listen, I don't care, because unfortunately this is totally what I am doing, that like for example, if I say that I do this thing 50 years ago, and after 50 years ago, after 50 years still you are doing the same thing, so it doesn't make sense. Okay, we have to cope up with the era of, this is the era of laptop, this is the era of mobile, this is the era of smartphones, touch screen. Okay, so if someone
Yes.
is trying to be in the era of their forefathers, unfortunately this is not true. Okay, the books are you know, just I will just explain this thing to you specifically. This message is for you, and through you to others. What is difference between research article? Only you will tell, please. Just I want to know, you know it or not. What is difference between research article and review article? Do you know about it, Eva?
Sir,
No problem.
sir,
Don't
it's
be.
better if you tell.
The good point is that I cannot come out of the mobile and punch you. Okay, so you are safe. Don't worry. Okay, so research article, as the name is telling, the research article is only like your synopsis dissertation is research article. Okay,
Yes, sir. Yes,
so
sir.
this is only on one research, and review
Okay.
article is on the basis of maybe 50, 100, 200 research articles. Okay.
Okay,
So
sir.
that one is
Okay.
review article. And the books are written on the basis of review articles. If you open any book
Hmm.
and go to the
Hmm.
references, you will find reviews of the review articles or other books. For example,
Okay,
if
sir.
they are telling about anatomy, they are telling about physiology, they are telling about pharmacology, maybe they are giving the references of some other pharmacology books or anatomy books or this books. Okay. So what's the problem? What's the problem that this is a religious belief to read a book
Hmm.
cover to cover. Okay.
Mhm.
And I can
Okay.
you will just honestly tell me that when you have started the training, what are the
Hmm.
things which you have told, which have been told for Morgan? First reading will not give you anything.
Okay, yes, sir.
You have to tell, you do 100 readings. Okay.
Sir, I was
Number one.
suggested Morgan for
Number
initial.
one. And they tell
initial.
you that you will not understand in first reading. In second, third reading, you will start knowing it. Number one. Number two,
Yes.
examiners read Morgan.
Hmm.
Okay.
Okay, sir.
We pass the exam by Morgan.
Okay.
These are the things. Have you listened or not?
Yes.
Okay. So all, unfortunately, they are all wrong. They are terribly wrong. If you ask your any examiner, you are opening maybe 10% examiners will be doing it, 20% examiner.
Hmm.
But actually, after some time, you have your own concepts and you are following it. Or even, for example, if they are doing like that, you should
Hmm.
not do that. Okay. Because
Hmm.
if you
Hmm.
are just trying to follow the herd, if that's the same thing will occur which is occurring in our holy country. Okay. So if you
Yes, sir.
want to be like that, okay, fine. I cannot. But you see, the Lang series books are like this. Uh,
Hmm. Hmm.
Harper, biochemistry, Yah.
Yes, sir.
RJ Last, anatomy, Yah.
Yes.
Genong, physiology, Yah.
Titan.
No, Guyton is not.
Writing
Katzung,
is good.
Katzung. Then clinical microbiology and pathology. Okay. So it is just
Okay.
like if you have 7 crab people standing and the 8th one is saying that I look like them, but I am not part of them. It is like that. Actually, its pattern is it's a notes. Okay. You will find one thing in one page, page number 78. The remaining part will be on 255 number page. And the remaining will
Hmm.
be on 378 and the remaining will not be there. So
Hmm.
how will you link it? Okay. I will give
Hmm.
you one example for it, that if you want to understand pheochromocytoma, okay, you
Hmm.
should be starting from what, from where you should be starting, or you should be starting from the catecholamines metabolism.
Hmm.
Okay, how they are produced and how they are degraded. You will find it in the
Hmm.
chapter of pharmacology. It is there in
Hmm.
pharmacology written somewhere. Okay. And then rest of the things will be somewhere else. Rest of the things will be somewhere else. What the hell? What are you trying to do with yourself? And if you for the people are afraid of articles, I just try to give them request them that just try to have, like, for example, we discuss this topic, this is related to gynae ob. You don't need to read each and every article. For example, if you come here and you find amniotic fluid, maternal collapse, amniotic fluid, what do you think? You will find different stories? No. The same thing. In front in this our discussion, I just had a look on different articles and I found the same things everywhere. You open this article, you will find so you can do like that. You can have the effect or look on the key points, the summary. You will come to know. You just have a look on the headings, timing, risk factors, pathophysiology, incidence. You can have this. You see, this is the business end. Okay. This is in the other article we did not find this thing, that what is a component of amniotic fluid. This is extra thing. You just copy paste it and put it on you take a printout or you put it in Word and you note it down, or you note it down where you pen. Now you don't need to open it again, because the same things will be written about pulmonary system, coagulation system, diagnosis, Like you see, this is a very good chart. It looks very nice. Mechanical block, endogenous mediators, as I was telling you. Physical obstruction, vasospasm, resulting in acute pulmonary edema or pulmonary hypertension, hypoxemia, right heart failure, survival or death. If survival occurs, it will result in left ventricular failure, pulmonary edema, neurological impairment, DIC. Okay. So just tell me one thing. Is there any?
Excuse me, sir. Excuse me,
Yes.
sir. I have so many people were telling, sir, we lost your this one, this Google Drive. Your so what should be the you have told us that there are star messages. I haven't picked that. Yesterday you were
Star
talking about that.
messages. Yes, I can repeat it again. For example, I send this message daily, and then people ask, "Sir, can you tell me this thing?" Anyways, I can reply anytime. But if you want to star this message, you just click it and you star it. In your mobile, your option will be to select it and make it star. So, and then you
Okay.
go here, you will find the star messages. Okay, and you will find it here. So this link is about this is YouTube channel link. You will find all the recordings there in the playlist. This is Telegram. I've made it just I don't use much it. This is one is this Zishan anesthesia data, which has all articles and everything. And this is actually review articles year wise, which I showed yesterday. That I'm unable to do arrange them. But if you want to do year wise, it is also a good thing. And this is have some podcasts too. Okay.
Okay, sir. Okay.
So please,
Sir,
it's a request.
because that is a very fine way to, sir, you are telling us it is a very fine way to take from the that article or main points. Then after reading MCQs, then you can quickly read the things, sir.
Yes, you can do, and you know, whenever you are receiving, if you will take this group as a social media tool, you see, if you see, unfortunately, I cannot show you my whole WhatsApp. I am doing everything. I'm in politics. I'm in religion. I'm with family. I am doing everything all the time. Can you see the messages? Okay. So remember one thing, if you want to do something, you can do it. Where there is a will, there is a way. But unfortunately, why you are following others blindly? Because you have switched off your brain. And you think that what others are saying are right and you are wrong. But remember
Sir,
one thing.
you are also part of Ghaznavi Special Force, I guess I've read. Right.
So many groups. Okay, so anyways, thanks a lot for your presence. We will do, I think this topic was, what was that? It was analgesia for circumcision. Okay. So you were talking about treatment, Atiq bhai. There is no support. There is no specific treatment according to the situation. Okay, whatever happens, you treat it. If there is uterine dilatation, you will be using uterine tonics. If there is blood pressure, low blood pressure, you will be starting inotropes and vasopressor. You are doing some monitoring. You are seeing the right ventricular things or left ventricular thing. If the right ventricular failure, you might need to use this what is that? Inna lillahi wa inna ilaihi rajiun. What is the name of that medication? Usman, what is the name of this phosphodiesterase inhibitor for right heart failure? The name
Sir,
slipped out.
Milrinon.
Sorry, thank you. Milrinon. Okay. So if you have a right heart failure, you will be using Milrinon with cover of epinephrine or norepinephrine, because Milrinon will cause vasodilatation. Okay. So maybe you need to give norepinephrine to support the vessels. So rest of the thing.
Is there a role of sir? Is there any role of heparin in the amniotic fluid embolism?
There is definitely, if there is DIC, what will happen? Do we give heparin in DIC or not?
No, sir. We don't.
We give. We have to give. What is DIC?
Sir, it depends which stage is
Which
of
state, but
DIC.
you cannot say that you don't. You might have to. You will
Yes,
have to.
yes,
Because it is
yes, sir.
intravascular it is consumption coagulopathy.
Yes,
Okay.
initially we can give, but in later stages, I think you should avoid.
Yes, actually the rationale is that you will be trying to, because DIC will not occur spontaneously without a reason. DIC will have some triggering factor, some infection, abruption, amniotic fluid embolism, whatever the cause is. Okay. So you will treat the cause. Then the trigger, when the trigger is gone, it will come back. The patient will come back. And if you are expecting some things, you will be having this cover, and you will use it according to the situation. Okay.
Sir, basically we use tag in DIC and then decide what to give.
Yes. Okay. So
So what
thromboelastography.
about shunting? Shunting.
You cannot do, you cannot treat shunting in pulmonary embolism or any kind of embolism. You can give heparin or any like TPAs. Otherwise, none other treatment is present.
There is no other treatment. Okay. Okay, everybody, thanks a lot. Thanks a lot, everyone. No, if any question, just feel free to ask. Okay. Yes.
Thank you, sir.
Somebody.
but-
Yes, I will. Before finishing, I will. I will ask to all of you one question. Somebody asked me that you have a patient with a coagulopathy, and you want to give a block, or for whatever you want to do a procedure. So, how much time before you will give FFPs or platelets or cryoprecipitate? And after how much time you can do the surgery? Who will answer? Yes, Atik bhai.
Sir, can you, sir, couldn't got your.
You are replacing some factors, or you are replacing FFPs, you are giving platelets. And after how much time you can proceed with, for example, if you have a patient with low platelets, so like you are transfusing platelets. So after how much time you can do the block? This is the question.
4 hours.
4 hours? No. Why
No,
to
no,
wait?
you can proceed. You can proceed
the
after
same hour.
After
Same
completion.
hour.
Yes, after completion of the transfusion, you can give because they don't need any time to activate themselves.
Yes. Okay. It's Nadeem bhai, actually, your question, that is something else. If you have given heparin, then you have to wait for 4 hours. If you have given Claxane, then you have to wait for. I'm talking about platelets. Okay. I'm talking about FFPs. So immediately, as soon as it is finished, you can do it. Okay. So that was the question being asked.
Sir, there is one question more, sir. If the patient is having 6 HB and the gynecologist want to she want to transfuse, and if it is better before or after the C-section, sir? I think so. It should be after C-section, sir.
No. 6 hemoglobin is very low. 6 hemoglobin is very low. And one unit of PRBC will not be enough. Okay. How much is average blood loss in cesarean section?
1000 ml.
Okay.
No,
So you want
1500 to 2000. In normal delivery, it is 1000 to 1500. In C-section,
no.
it is 1500.
In normal delivery it is 700, 500
And
to
in
700. In
just a second,
in
please.
C-section it is 1000 ml.
No,
and it is,
Usman. Yes, you are
But
right.
delivery-
Atik bhai, your answer is right. Usman, your answer is wrong.
Okay,
It
okay,
is-
sir.
No, not right like that. Around 500, 700 ml in normal delivery, 500 ml. Okay. And in cesarean section up to 1 liter. Okay. So you don't
Okay,
want hemoglobin to come at 4. Okay. You don't want hemoglobin to come at 4 before giving transfusion. So you will definitely give before. Okay. Because you are anticipating that there will be some, at least, okay, for example, not 1 liter, at least 500 ml blood loss will occur, at least. Okay. So her hemoglobin will fall down even further. So that will be critical. Okay. So I think, Nadeem bhai, do you understand?
Yes, thank you.
Okay.
Excuse me, sir. There is for tomorrow. There is one topic, a very small topic. You should
This is not
include
small
one.
topic. Remember one thing. This is not small topic.
Okay, sir. Okay, okay.
We will discuss model. We will discuss.
Okay, okay, sir. Okay.
Okay. Actually, I have discussed this topic in regional anesthesia about nerve blocks below the level of umbilicus. So I have done a number of things before, but we will just try to do it in some different way. We will just try to have some options, different options. Okay. So thanks a lot, all of you, for your presence. And you see, we should give good idea to our juniors. Unfortunately, because we are happy to finish our guidance in 1 minute, please read Morgan. हमने भी यही पढ़ी थी. So this is not an answer actually. For that you need to have some spare time for others to invest on them. Okay. So thank you very much. Bye bye. Assalamu alaikum.
Okay, sir. Allah Hafiz.